A warm welcome to the fifth PharmaCross webinar. At PharmaCross, we are committed to supporting the practicing veterinarians. To help our veterinary customers maintain and enhance their knowledge and skills and keep pace with the current standards in the field of veterinary medicine, we launched the PharmaCross webinar series. Today, we are running the fifth webinar, and we have the honor and pleasure to have as our invited speaker, Dr. Andrea Zatelli, Associate Professor at the Department of Veterinary Medicine in the University of Bari. Professor Zatelli will speak on chronic kidney disease in dogs and cats. What's beyond creatinine? Professor Zatelli graduated with honors from the University of Parma in 1990. He followed several postgraduate training courses in Germany and the United States. From 1998 to 2012, he's been working as a practitioner in Italy with a special interest in canine and feline nephrology. From 2013 to 2019, he has been a veterinary consultant in Malta. His research involves nephrology and urology of cats and dogs, particularly renal damage subsequent to vector-borne disease and diagnosis and treatment of canine glomerulopathies. In 2005, he was awarded from the International Renal Interest Society in recognition of outstanding fundamental and clinical research performed by an individual in the field of nephrology. He is a founding member of the Canine Leishmaniasis Working Group and is the author and co-author of publications in peer-reviewed international journals, chapters of books and monographs dedicated to nephrologic and urologic disease of dogs and cats. He's an active speaker at national and international courses and congresses. Currently, Andrea Zatelli is Associate Professor at the Veterinary Medicine Department of the University of Bari. Without further ado, I would like to ask Professor Zatelli to start his lecture. Professor, the stage is yours.
Thank you. Thanks for the nice presentation, and thank you for inviting me and to offer me the opportunity to talk about chronic kidney disease in dogs and cats, and particularly to focus on what is beyond creatinine. As you know, probably much better than me, chronic kidney disease is the most common diagnosed nephropathy in both dogs and cats. Something is changing because in the 90s, the idea was that the incidence of chronic kidney disease was approximately of 1 in 3 cats and 1 in 10 dogs. Probably the reason why there is a really low incidence of chronic kidney disease in dogs compared with that one in cats is that at that time, and is absolutely true, our colleagues in US were working on nephropathies in both dogs and cats. And all around Europe, the attention on chronic kidney disease was not the same that is today. This is the reason why, if we move to the millennials time, the incidence of CKD in dogs is tremendously increasing, and as you can see, right now we consider an incidence of 1 in 3 cats and 3 in 10 dogs. That is almost the same. Obviously, this means that probably there are no other diseases that can affect both dogs and cats with an incidence like that one of CKD, even when we are talking about dermatitis or osteoarthritis or myocardiopathies, and many other diseases. When we talk about chronic kidney disease, starting from the incidence, we must remember that obviously there are many reasons why the number of dogs is tremendously increasing, and one of these is and are related to transmitted, for example, vector-borne diseases like leishmaniasis and ehrlichiosis, but also pyroplasmosis and Lyme disease. But there are many other diseases that we discovered during the last decade are strictly related to the development of nephropathies in both dogs and cats. Many chronic inflammatory diseases, like for example, periodontosis and dermatitis. Chronic dermatitis and periodontosis are strictly related to the development of chronic disease. Today, we are used to stage a patient affected by chronic kidney disease, referring to the International Renal Injury Society staging system that has been presented in 2006, is evidence-based, is dedicated to dogs and cats affected by chronic kidney disease. And what is important to remember is that the disease, if we want to consider it as a chronic one, must be present at least for a period of 3 months or longer. The duration obviously can be estimated starting from the medical history of the patient or inferred from physical examination findings, or even by renal structural changes identified through imaging studies, for example, X-ray examination or ultrasound examination, or even via renal pathology evaluation. The diagnosis of CKD is mainly based on value of creatinine and SDMA, and I would like to highlight even that if creatinine is within the normal range but is increasing time by time, we can consider that the patient can be affected by a kidney disease. And the same happened with the SDMA. I know that you have confidence with SDMA, that is a new marker, a new biomarker for kidney function, and is excreted by the kidneys, highly correlates with glomerular filtration rates, and is able to identify earlier than creatinine a reduction in kidney function. For example, when we refer to creatinine, usually we can identify an increase above the reference range of serum creatinine when we have lost at least 75% of kidney function in both dogs and cats. But with the SDMA, we are able to identify a reduction in kidney function even with a loss of 40 or as little as 25%. We can obviously use also an abnormal kidney imaging just to say, like in this case, that the kidney is abnormal, and probably because we have, for example, a small kidney, big kidney, the reason can be related to a chronic kidney disease that is affecting the left kidney in this picture. Another reason why we consider a patient affected by chronic kidney disease can be related to the evidence of proteinuria. A persistent renal proteinuria, that means a UPC value that is above 0.5 in dogs and 0.4 in cats, is related to chronic kidney disease. Usually, we consider a persistent renal proteinuria with an interval in time of approximately 2 months. Or we can also diagnose a chronic kidney disease patient using both creatinine and ESA MA that are increased, are above the normal range, plus the urine specific gravity that is lower than the normal one. And normal specific gravity is considered in dog with a value of 1030 and above, and in cats for 1035 and above. We also must remember that some cats are able to concentrate urine even in case of chronic kidney disease. So we can find some cats, for example, with an increased creatinine level and increase in SDMA, but with a good level of urine specific gravity that is maintained above 1035. So sometimes there is no correlation in cats, particularly in the early stages of the disease, between increase in creatinine and SDMA level and reduction in urine specific gravity. In this case, obviously, we will refer to creatinine and SDMA. Once the chronic kidney disease has been diagnosed, we can continue staging the chronic kidney disease. The staging system that has been proposed by the International Renal Interest Society is, first of all, based on the level of creatinine and SDMA. The staging system is related to creatinine and has been upgraded in 2019. The value that are reported in the slide are increased if compared with that one that has been published in 2006, and even in the previous version of the iris staging system that has been published in 2017. At this point, we can consider a normal range for canine with a creatinine value up to 1.4 milligram per deciliter, and in feline 1.6 milligram per deciliter. In 2019, the idea was to increase particularly the value of the upper range of stage 2 in canine, and this is the reason why at this point the stage 2 in canine is diagnosed with a creatinine level that is between 1.4 and 2.8 milligram per deciliter. The reason why was decided to increase the upper level of the value of stage 2 in canine is related to some aspect of the disease that we are going to talk just in a few minutes. The second point, after the stage based on creatinine value, is to consider the patient as non-proteinuric for both dogs and cats. This means UPC value that is under 0.2, borderline proteinuria for a UPC that is between 0.2, 0.5, 0.2, 0.4, respectively for canine and feline. And dogs and cats are considered to be proteinuric for UPC value that are above 0.5 for dogs and above 0.4 for cats. Last, the patient will be evaluated for systolic blood pressure, and the patients are considered to be normotensive for a systolic blood pressure that is under 140, pre-hypertensive with a systolic blood pressure that is between 140 and 159, hypertensive for a value between 160 and 179, and severely hypertensive for any value that is equal or above 180. The last step is treatment of chronic kidney disease in dogs and cats. There are some points that I would like to remember. The first one is that is fundamental to provide the evidence that the treatment is able to influence outcomes that are really considered important for both pets and their owners. When we are talking about outcomes really important for pets and their owners, usually we refer to increased activity, increased appetite, amelioration of the body condition score, and obviously maintenance or increasing kilogram of body weight, decrease the episode of vomitus, decrease the incidence of uremic crisis and the renal related mortality. Why is it so important to think about outcomes that can influence the activity, appetite, body condition score, vomitus, uremic crisis, and renal related mortality? Because usually when we are presenting a treatment or some treatment options to an owners of a pet that is affected by a chronic kidney disease like chronic kidney disease are, there are three major points that we should always consider. The first one is cost. Sometimes owners are not able to start treatment or to accept the treatment that we are proposing only because they are not able, for example, to sustain the cost of the treatment. Meanwhile, we should consider the compliance and the well-being. What about cost? Many owners are convinced that therapy are expensive. There are many other things that they can do. Sometimes are not obviously able to consider that what we are considering for the treatment of the dog or the cat affected by chronic kidney disease is able to ameliorate the well-being of the patient. And this is the reason why we must be able to explain that there is nothing more expensive than a cheap therapy that does not work. I think that this is a really important concept, because if we are not thinking about the importance of the therapy and what we are waiting for, how we can evaluate the efficacy of the therapy that we are going to start and to perform. we will not be able to evaluate another aspect that is really important for the owner and is strictly related to the compliance. When we are talking about therapy and chronic kidney disease, particularly, we should consider that therapy in advanced stages of the disease are able to ameliorate the physical condition of the patient, are able to ameliorate the well-being. When we are talking about the early stages of the disease, the therapy that we are going to institute must be able to lower the progression of the disease. What is important to remember is that any therapy that we are going to consider must refer to a proper dose and the proper actives. It doesn't matter if you are referring to drug or feeding stuff, for example, because sometimes when we refer to feeding stuff and we don't care about a proper dose and the purity of the actives and so on, we are not remembering that, for example, sodium bicarbonate that you can find as an active that is able to control a metabolic acidosis is reported in a veterinary drug handbook, and there is a proper dose that you should administer if you want to control, for example, a metabolic acidosis secondary to renal failure. In dogs and cats, the initial dose is 8 up to 12 milligram per kilogram per os every 8 or 12 hours. It depends on the papers that we are referring to. So I would like to underline that in many cases, when we are talking about feeding stuff, really we must refer to a veterinary drug handbook, and we must refer to a proper dose. This is important because it's able to affect the compliance and the well-being. When we are talking with the owners sometimes say, okay, but if the patient is affected by a chronic, irreversible, and progressive disease, what can I do? What can we do? How is possible to treat the patient? How is possible to ameliorate the condition of my cats or of my lovely dogs? And sometimes we do not remember that referring to increased activity, increased appetite, amelioration of body condition score, and decrease the episodes of vomitus are absolutely related to the concept of well-being that is in the owner's mind. Owners are not thinking about serum creatinine. A large number of you have a large number of cases of dogs and cats that have been diagnosed as affected by chronic kidney disease, and a large number of owners are not able to understand that something is going wrong. They are only able to understand that the dogs or the cat is not in a good clinical condition because they are referring to decreased activity, decreased appetite, to the fact that the patient is losing weight, they are losing body condition score, they are increasing vomitus, but they absolutely do not know about the level of serum creatinine. So this is the reason why, if we are really able to consider these 4 points, usually we are also able to increase the level of compliance of the owner. Even if it's true that if the serum creatinine increase, usually there are clinical consequences that are described in this slide that you can observe. For example, nephroliths can be diagnosed in all stages of chronic kidney disease, up to 4. A dog or a cat can be proteinuria irrespectively of the stage. Usually, polyuria and polydipsia are diagnosed in stages 2, 3, or 4, and dogs and cats affected by chronic kidney disease in stages 2, 3, and 4, because of the reduction in ability to concentrate urine, are more predisposed to urinary tract infection. Hypertension is much more common in stage 2, but particularly 3 and 4 compared than 1. Hypokalemia in cats usually is related to reduction in appetite, a decreased appetite, the cat is not eating the proper amount of food per day, and this is the reason why, even if they have, for example, a hyper excretion of potassium with the urine, they can develop hypokalemia. And this more common in stages 3 and 4, even if we can diagnose hypokalemia in cats even in stage 2. A decrease in appetite, nausea, and vomitus is frequent in stages 3 and 4, and the same happened for the weight loss, dehydration, hyperphosphatemia, metabolic acidosis, hypocalcemia, and anemia. So this is the reason why I was telling to you before that at the end of 2018, the IRIS group decided to modify the IRIS aging system and to increase the upper level of creatinine in stage 2 for dogs. The previous value was about 2 milligrams per deciliter, but it was approximately impossible, for example, to identify many dogs affected by chronic kidney disease with the creatinine value of 2.1, 2.2 milligrams per deciliter, dehydration, weight loss, metabolic acidosis, and hypocalcemia. That is much easier to identify when the creatinine value increase, particularly with value that are above 3.5 milligram per deciliter. This is the so-called CKD flower, where the common signs are reported, and they include increased thirst and urine production, so polyuria and polydipsia, usually in stages 2 up to 4, decreased appetite and weight loss, bad breath, vomiters, sore mouth, weakness, lack of energy, and increased sleeping. Polyuria and polydipsia are obviously well known in dogs and cats affected by chronic kidney disease, even if probably the decreased appetite and weight loss is the more common clinical sign that is reported by owners. Owners usually are not able to understand if the dog or the cat, particularly in early stages of chronic kidney disease, are assuming a quantity of water that is above the normal quantity. Owners are not able to understand what does it mean for urea and polydipsia. But owners of both dogs and cats are able to understand what does it mean decreased appetite and weight loss. And decreased appetite and weight loss are the two most commonly reported signs in dogs and cats diagnosed as affected by chronic kidney disease. Sore mouth. Sore mouth usually are well represented in advanced stages of the disease, usually in dogs and cats with creatinine value that are above 3.5 milligram per deciliter. What is important is that usually the sore mouth are not strictly related to a particular level of azotemia, but seems that they are more present in dogs and cats that are previously affected by parodontosis. Depression, weakness, lack of energy, and increased sleeping. Sometimes they are mild, sometimes they are extremely severe. Some patients are really depressed. This is a patient that is not anesthetized, is a normal one, is severely depressed and affected by a chronic kidney disease in advanced stage, in stage 3-4, approximately 5 milligrams per deciliter. An important paper that has been published in the Journal of Veterinary Internal Medicine in 2013 demonstrated that dogs in UK affected by chronic kidney disease had a survival probability of 50% in iris 3 and iris 4, respectively at 20 days and approximately 4 months. Obviously, if we consider that there is a really low possibility of survival time that is above 4 months, even in iris 3 for dogs affected by chronic kidney disease. And if a dog is severely depressed, vomiting, losing weight, they have no activity, is normal that sometimes put to sleep the patient can be the least and then hardest decision, but I know that many of us, even if it's really hard also for the vet, can decide it because it's a matter of compassion for the patient. But I would like to remember that when we decide to put to sleep an animal because of depression, decreased activity, decreased appetite, vomiting, and many other clinical signs that we were talking about before, usually our decision is based on creatinine level. What I mean is that, for example, in the white dog that was severely depressed with a creatinine value of 5, And with the decreased appetite, the dog is losing weight, the dog is vomiting, there are sore mouth. After 2 days of IV fluid rehydration and administration of some drugs, the clinical condition continued to be the same one that we saw before. Our decision is based on the level of creatinine of 5. The reason why is that, for example, with the same clinical sign, if the level of creatinine is not 5, but for example is 2, probably we will not decide to put to sleep the patient because we will start to think about something different from creatinine. But when an owner is asking, what can I do? The dog is really depressed, or the cat is really depressed. They are losing weight. There is a lack of energy. They are always sleeping with polyuria and polydipsia. They are vomiting all day long. What can we do? What we should do is to think about the word beyond creatinine. And the word beyond creatinine is probably that one that we are not always thinking about. Because our clinical signs, consequence of electrolyte disorders and acid-base imbalance, or azotemia, or both. For example, metabolic acidosis and electrolyte disorders are able to cause decreased appetite, weight loss, vomitus, weakness, depression, lack of energy, and increased sleep. And for me, this is really important because this is the word beyond creatinine. Even if it's true that I'm not able, in a patient affected by chronic kidney disease, to decrease the level of creatinine, is true that I can try to control electrolyte disorders and metabolic acidosis because I have a lot of drugs and active substances that are able to do that. Obviously, this evening we are talking about what is possible to do, not with a 24 hours a day in hospital presence of the patient, but what we can support, what we can start to do with the owner, because we want to institute a therapy for the patient, and the owner can treat the patient at home. First of all, I would like to talk about hyperphosphatemia. Hyperphosphatemia is a well-known electrolyte disorder, but something changes during the last decade because even if it's true that obviously we perfectly know about hyperphosphatemia, hyperparathyroidism, and the impact of hyperphosphatemia, hyperparathyroidism in the progression of chronic kidney disease. What we discovered is the fundamental role of the fibroblast growth factor 23. And we discovered that the FGF23 is strictly related to the phosphorus level, but within particular range that are related to the stage of the disease. And this is the reason why, since the period that was approximately 15 years ago, we were used to consider an animal hyperphosphatemic with a phosphorus level above 6 milligram per deciliter, for example. Right now, everything changed, and we consider in stage 2 an animal hyperphosphatemic with a phosphorus level that is above 4.6 milligram per deciliter. In stage 3, the animal is hyperphosphatemic with a phosphorus level that is above 5 milligram per deciliter, and in stage 4, above 6 milligram per deciliter. The fourth therapeutic approach for hyperphosphatemia is the renal diet, administration of a diet with a low content of phosphorus. Sometimes, particularly in the early stages of the disease, the renal diet alone is able to control hyperphosphatemia, but in some cases, when the disease progresses, we are not able to control hyperphosphatemia with the renal diet alone, and we are used to add a phosphorus binder to the renal diet. Today, the two products that we are used to administer are calcium carbonate and ketosan. The first one at 90 up to 150 milligram per kilogram per day, and the second one at 50 milligram per kilogram per day. A large number of products is based on both calcium carbonate and ketosan, and the calcium carbonate can also be of utility in control hypocalcemia in advanced stages of the disease. When creatinine level increase, is easy to identify hypocalcemia and metabolic acidosis. In case of hypocalcemia, must be highlighted that if we are referring to the total calcium, usually not more than 10% of dogs and cats affected by chronic kidney disease are hypocalcemic. But when you are able to evaluate the level of ionized calcium, the percentage of dogs and cats affected by hypocalcemia with serum creatinine about 3.5 milligram per deciliter is approximately 50%. So much, much higher than that one that you can identify referring to the total calcium. With the metabolic acidosis, we should consider that approximately 30 up to 50% of patients in stage 3 and at least 75% of patients in stage 4 are in metabolic acidosis that is a consequence of renal failure. Hypocalcemia and metabolic acidosis have a great impact on well-being, activity of the patient, on muscle mass, maintenance of body condition score, and so on. Both can be controlled using calcium carbonate for hypocalcemia and sodium bicarbonate. Calcium carbonate and sodium bicarbonate are administered per os, and lactate trigger solution is my preferred IV solution, and the reason why is that obviously you are able to control hypocalcemia, and in part you will be able also to control the metabolic acidosis. If you are administering a normal saline, you will be able to reduce the blood pH shortly. I would like to show you what happens when we are able to control electrolyte disorders and metabolic acidosis in both dogs and cats affected by chronic kidney disease. For this reason, I would like to introduce you a dog. Is a mixed breed spare female, 5 years old, that is severely depressed with muscle contractions, weakness, but with a body condition score that is maintained, is 3 on 5. The dog started with a therapy with a renal diet, key protectors, so calcium carbonate and sodium bicarbonate, and lactate trigger solution daily. And I will show you some blood value at T0 and after 6 days of treatment. As you can see, the level of creatinine is absolutely the same. It was 6.2 milligram per deciliter pre-therapy, and is 6.4 milligram per deciliter post-therapy. Blood pH is not normal but acceptable, 7.29 and 7.33. Bicarbonate are mildly decreased, 17.3. They increase up to 19.4 post-treatment. But the dog is severely hypocalcemic with ionized calcium of 0.96 that rises up to 1.16 post-treatment. And you can see here the muscle tremor. Muscle tremor and contraction are really easy to identify in dogs affected by chronic kidney disease. And this is what happened after 6 days of treatment. There are no more muscle contraction at all, even if creatinine is absolutely the same, and the dog was absolutely more active. This was reported by the owner, obviously. So it is important to remember what can we really control and how the clinical condition of the patient can change only because we are going to treat something that is called calcium. The second clinical case is a German Shepherd, male, 10 months old, depressed, polyuric and polydipsic, with decreased appetite and a reduction in body condition score that is evaluated in 2 on 5. The therapy was based on renal diet, key protect, casein omega-3, and I will show you the blood value before and after 8 days of treatment. Creatinine pre-treatment was 8.9, post-treatment was 8.3, a blood pH of 7.36, 7.34 post-treatment, bicarbonate 16.9 and 18.9, and ionized calcium of 0.65, severely decreased, with a normal value post-treatment of 1.30. On the left side, this is the dog at the time of presentation, the first day. This is a 10-month-old German Shepherd male and is absolutely depressed, and you will see what happened with only the calcium normalized here on the right side. So before, with a really low level of calcium, and after, with a normal level of calcium. Same creatinine, above 8. This dog was enrolled in a clinical trial and he survived with a creatinine value of approximately 8 for 15 months. This was the first dog enrolled in a clinical trial in January, and he was euthanized because of uremic crisis. In April, he was included in January 2016, and he was euthanized in April 2017. My last clinical case is a dog, mixed breed, spare female, 13 years old, severely depressed, anorectic, polyuric and polydipsic, is losing weight with a body condition score of 2 on 5. The therapy was based on a renal diet, 2 days of feeding tube, key protected, lactate drinking solution, and sucralfate for the first 72 hours. I will show you the value at T0 and after 9 days of treatment. Creatinine value of 4.5, 4.7 after 9 days, a blood pH of 7.05, severely acidotic, and 7.45 post-treatment, bicarbonate of 7.1, 19.4 post-treatment, ionized calcium of 1.2 and 1.1 post-treatment. In this case, the dog is the same one that we saw before, that one that was really and severely depressed, even after 2 days of lactate, ringer solution, IV treatment, and the dog was hospitalized. And this is what happened after 9 days. Same dog, same level of creatinine, but the dog is not still acidotic. We were able to control bicarbonate level and the pH level. So this is the reason why during our clinical trial we enrolled 23 patients with 19 patients that reached the endpoints, and 4 were transferred, 3 because they were still alive, and 1 lost at follow-up. And what is really interesting to me is that the survival probability was 50% at approximately 9 months, median and median one. So this is demonstrating that if we are able to control electrolyte disorders and metabolic acidosis, we are really able to affect the clinical conditions, and probably they are much, much more important than azotemia and than the level of creatinine. This is the reason why in advanced stages of CKD, prior to final and irreversible decision, because when we think about put to sleep an animal, we cannot change the therapy after that. We must always consider to institute treatment able to control metabolic acidosis and or hypocalcemia, and re-evaluate the patient after a proper period of time. Sometimes colleagues are telling me, well, I have no possibility at all to measure the ionized calcium. This can be true because ionized calcium can be evaluated only if you have a hemogas analysis, and is the best way to measure the level of this ion. But I would like to show you that there is even at this link a canine ionized calcium calculator that is at your disposition by the veterinary medicine at Illinois. In red, there are the values that are mandatory and you must insert it: level of creatinine, albumin, total calcium, potassium, and chloride. And obviously it's not like to use a hemogas analysis, but obviously this can be a good tool that you can refer to for evaluate the level of ionized calcium in your dog. It is not available, unfortunately, for cats. And I would like also to share with you a brief formulary of the probably most used medication in dogs and cats affected by chronic kidney disease: calcium carbonate for hyperphosphatemia and hypocalcemia. You can also increase the quantity, but usually the starting dose is between 60 and 90 milligrams per kilogram, divided with the main means every 24 hours per hour, so mixed with food. And sodium bicarbonate in case of metabolic acidosis at a dose of 8 to 12 milligrams per kilogram every 8 to 12 hours. Usually I start with a dose of 8 up to 12 milligrams per kilogram every 12 hours, and I recheck the patient, or I consider the clinical condition of the patient approximately after 1 week of administration per os. Maropitant is a really good option if you want to control nausea and vomiting, not only during the acute phase of the disease, or if you have an acute kidney injury on chronic kidney disease, but even in case of chronic use. The reason why maropitant can be used even in chronic use in both dogs and cats is that you can reduce the dose by 2 to 1 milligram per kilogram, and you can administer it every 24 hours per os or subcutaneously. You can use also mirtazapine in case of hyperexia at the proper dose for cat and dog. Some colleagues are telling us that mirtazapine is not working properly in dogs and cats, particularly in advanced stages of the disease. In my opinion, the reason why is that if you are administering mirtazapine, but you didn't control in advance metabolic acidosis, obviously you will not be able to evaluate the effect of mirtazapine. So a practical approach is to control, for example, sore mouth. Use at least also analgesia if sore mouth are present. Start treating hypocalcemia and metabolic acidosis, if the animal is not eating and continue vomiting and with nausea, we can try to introduce maropitant. And if the animal is still not eating, we can try only at this point to introduce mirtazapine as an appetite stimulant. And also there are two gastrointestinal protectant. One is omeprazole and the second one is sucralfate. My preferred one is sucralfate. So now we have some questions. The first question is, in IRIS stage 3, the goal is to achieve a serum phosphorus concentration below 4 milligram per deciliter, 5 milligram per deciliter, 6 milligram per deciliter, or none of the previous answers. Remember that we are in stage 3. Okay, the right answer was 5 milligram per deciliter, and the majority of you, 48%, voted for 5 milligram per deciliter. This is the new range that was introduced in stage 3. 6 milligram per deciliter is referred to stage 4. In stage 4, phosphorus must be under 6 milligram per deciliter, and 4 milligram per deciliter, unfortunately, is a value that is not related to any stages of the disease. Another answer is related to hypocalcemia and metabolic acidosis. Hypocalcemia and metabolic acidosis are more represented in all stages of CKD, with serum creatinine above 3, with serum creatinine above 3.5, with serum creatinine above 5. Try to remember that we are asking if when they are more represented, and not when they start to be represented. The higher percentage is with a serum creatinine above 3.5 milligram per deciliter. Well, really you are in the right way, but this is not the correct answer, because the question was when they are more represented. And obviously, even if it's true that hypocalcemia and metabolic acidosis start to be represented with creatinine value above 3.5, obviously increasing the level of creatinine, you will increase the percentage and the prevalence of metabolic acidosis and hypocalcemia. A 5 milligram per deciliter is the value above which we are in stage 4. And if you remember, we told that in stage 4, approximately, and at least 75% of dogs and cats affected by CKD are in metabolic acidosis. And with a creatinine value between 3.5 up to 5, usually the percentage is between 30 and 50%. But anyway, it's okay to me the fact that we start to consider that increasing the level of creatinine, something different happens, something that is beyond creatinine, hypocalcemia and metabolic acidosis. The next question is related to clinical signs. Clinical signs. Persistent metabolic acidosis may cause a variety of adverse clinical effects, including anorexia, nausea, vomiting, weakness, and lethargy. Increased protein catabolism leading to malnutrition, muscle wasting and weight loss, and finally, all previous answers. Okay, this is fantastic. All previous answers. Metabolic acidosis has a tremendous impact on the clinical condition of the patient, and is able to cause anorexia, nausea, vomiting, weakness, lethargy, is able to increase protein catabolism, leading to malnutrition, and muscle wasting and weight loss. So remember, there is not only creatinine. Maybe creatinine is really high, but if there is a persistent metabolic acidosis related to renal failure, we must consider to treat metabolic acidosis, because we are able to control all those clinical effects. Next one, metabolic acidosis treatment. The most effective therapy includes aluminum hydroxide at 40 milligram per kilogram body weight orally twice or 3 times a day. Sodium bicarbonate at 8 to 12 milligram per kilogram body weight orally twice or 3 times a day. Renal diet plus sodium bicarbonate at 8 to 12 milligram per kilogram body weight orally twice or 3 times a day, or a combination of aluminum hydroxide and sodium bicarbonate. Okay, perfect. The majority answer renal diet plus sodium bicarbonate, 73%, 90% sodium bicarbonate at 8-12 milligram per kilogram. The right answer is related to the question. The most effective therapy includes is the number 3, because renal diet plus sodium bicarbonate is absolutely the best option. My second option is sodium bicarbonate at 8 to 12 milligram per kilogram body weight, twice or 3 times a day. If the dog is not eating a renal diet, in this case, usually we are referring to other diet, but we are adding sodium bicarbonate, and it's really important because we have not the buffer that usually are within the renal diet. So with the renal diet as a first option, sodium bicarbonate alone added with another kind of diet as a second option. Aluminium hydroxide is a phosphorus binder. Has no effect at all on metabolic acidosis, and at least they can be used to reduce the absorption of phosphorus within the gastrointestinal tract. Next one is related to hypocalcemia prevalence. Recent studies demonstrated the prevalence of hypocalcemia in patients with serum creatinine above 3.5 milligram per deciliter, above 30%, above 50%, above 70%, or 100%. Majority of you answered the number 2, about 50%, and is the correct one. Even if 70% can be related to really advanced stages of the disease, because there is usually an increase in percentage. But based on the studies and referring to serum creatinine about 3.5 milligram per deciliter, the correct prevalence is about 50%. Obviously related, we must remember it, to ionized calcium and not to the total one. So this is the end of my presentation, and hope that something is much easier to understand now, thinking about patients affected by chronic kidney disease, particularly in advanced stages of the disease. And I hope that all of us will be able in the future to start to try at least to control some metabolic condition like acid-base imbalance or electrolyte disorders. Thank you really for your attention, and I will be glad to answer to some questions if there are.
Thank you, Professor Zatelli, for a very interesting lecture full of practical advice and information. And I would like to invite our audience to type their questions in the chat so that you can answer.
Hello, Ellie.
Yes, I'm here. We are waiting.
Yes, I have no question right now.
Well, we just need to give them some time and
Yeah.
they will come up with their questions.
Okay, I think that I can start with the first one, that is how can we increase compliance? This is really good question. I don't know if the colleague is referring to that one of the patient or the owner. Can you write it? Can you text it?
And this is about client compliance.
A client one. Okay. To me, the most important point is be able to demonstrate that our therapy is, with our therapy, we are able to increase the activity, reduce vomiters, reduce nausea, and stop the losing weight period, ameliorate the body condition score and the well-being. My approach usually is just to say to the owner that they must not care about creatinine level, because this is important for us, for the staging system, and for monitor the progression of the disease, for the follow-up. They must consider only the well-being of the patient. If you start treating dogs and cats affected by chronic kidney disease, thinking about a treatment that is step by step, even in advanced stages, as I was telling to you before. For example, at the beginning, you, in some cases, must be obliged and forced to hospitalize the patient, maybe because you need to rehydrate the patient, to administer some IV fluid, to start treatment for vomitus with the subcutaneous or IV administration of drugs. You must be forced to put a feeding tube and so on. But usually patients are hospitalized for at least and maximum 48, 72 hours. After that, the treatment can continue at home. At the beginning, sometimes the owner is coming every day during the first 7, maximum 10 days. And so during the first week or maximum 10 days, they are coming every day. You can control the patient clinically. You can administer drug, or you can continue just explaining to the owner what happened. But believe me, when a patient is affected by hypocalcemia, is in metabolic acidosis, and so on, you will be absolutely incredible when you will see that the creatinine will be the same as before, but the patient is absolutely another one. Even if the creatinine is 5 and 5 after 1 week, but if you are controlling electrolyte disorders and metabolic acidosis, your owner will be absolutely happy for what happened. Because usually cats and dogs start again to eat, they stop vomiting, and the compliance of the owner will increase for sure. What formula do you use to count the amount of lactated Ringer solution ml needed? Usually I consider an amount of lactated Ringer solution per day of 60 ml per kilogram in dogs and 40 ml per kilogram in cats. This is an IV administration plus dehydration. Dehydration means, for example, that with a 5% of dehydration, to a 10-kilo body weight dogs, I will administer 600 ml plus 5% on 10 kilogram, that are 500 ml in 24 hours, just to correct the hydration. Can sodium bicarbonate be given in a patient that has chronic renal disease and pancreatitis? The answer is yes. Obviously, usually they are probably not eating, so you should consider the administration by IV with other fluid. Does early neutering of a cat at the age of 3 to 5 months have effect to renal and urinary disease in later stages of life? Not to my knowledge. Thank you for your time. Thank you. Does an early neutering of a cat at the age of 3 to 5 months have effect on renal? No, it's the same. Or what is your opinion on controversial opinion of other researchers about feeding cats with meat instead of dry renal diet? It's a controversial opinion. I'm absolutely in agreement with you. There are two groups. I'm with the renal diet group, really, and the reason why is that right now we have several studies demonstrating that the administration of renal diet are able to prolong the survival time and the quality of life of cats affected by chronic kidney disease. Even if it is true that in some cases, because cats love meat, obviously, they are not so predisposed to a change in diet, particularly with a renal diet, with a controlled level of protein. And obviously, in this case, we must follow the cats. But in my opinion, and if it's possible, I would prefer to administer a renal diet if the cat is affected by chronic kidney disease. There is a question that is, do you use ACE inhibitor and alloprep, for example, in a decompensated CKD? I'm asking this because it will probably cause a higher creatinine, but based on the presentation, it would be better to use in order to reduce proteinuria, etc. And not be worried about the creatinine level. No, Oscar, absolutely. I will not use ACE inhibitor if the animal is dehydrated. So, first of all, you should consider the proper hydration, correction of electrolyte disorders, and when the animal is hydrated and without electrolyte disorders, you can start to use ACE inhibitor in case of proteinuria. My preferred one is enalapril. What is your opinion on using homeopathy on renal problem? Viva, I'm sorry, but I have no opinion. This means that to me is not yes, not no, but I really don't have idea about that because it's out of my focus and my studies. So I really cannot say anything about it. We have a cat that has lived, she is 12 years now, and it's our 5th year already when we live with everyday grip of ringer lactate, also forte corti protect casing made solidado and renal. In general, it's for human with kidney disease, but it works for cats as well. And of course, we choose a strict renal diet KD. So I just wanted to share my impression that the complex of solution works really well. During the first weeks, a lot of people suggested to put our cat to sleep, but she is still alive and is some kind of hearingly training, inspiring other people to take care of their pets. Ilse, I totally agree with you. What I usually say is you must try. Don't put to sleep your patient because this should really be the latest and hardest decision. Sometimes it's true, it's compassion, but don't do that. You must try to treat your patient. Don't think only that creatinine is a proper way to take a decision, because there is really a world that is surrounding and is beyond creatinine. Okay, if
Yes, Professor, I think you have answered all the questions.
okay,
I would like to thank you once again for
thank you.
very interesting lecture, for all this useful and practical information that you shared with us. I would like to thank everybody who has joined us today. I wish you a lovely summer, and we look forward to seeing you again in one of the future PharmaCross webinars. Thank you very much.
Thank you. Thank you.
Goodbye, everybody.
Thanks for your patience. Bye. Thank you.
Bye-bye.